but I think there is a lot more than that. So before we do give the adjuvant therapy, what are the tests we need to do to have it as a baseline? We need to have a CEA, particularly if the patient has a CEA that's high before. We need to have CT scan of the abdomen, pelvis, and the chest with contrast. And if some patients cannot take the CT scan, we should do the MRI of the abdomen and pelvis. And in rectal cancer, if we can do rectal endoscopic ultrasound, it's really nice because we can get a good sense of how the tumor is, where the tumor is. PET-CT is not routinely indicated, but if you have a questionable CT or MRI finding, we need to do that. And of course, if there's stage 2, we always like to have microsatellite stability analysis because that gives us whether we need to give chemotherapy or not chemotherapy. Of course, we have to understand the limitation of PET-CT. CT is not a substitute for the PET, for the regular CT scan with contrast because it is lower resolution compared to the regular CT. And PET may not pick up lesions that are smaller than 1 centimeter. And we have to also be cautious about interpreting these lung lesions in the infection endemic area, like here, where we have tuberculosis and pneumonia, because they can also give positive finding on PET-CT. For example, there was a study that showed sensitivity is 89% and specificity is only 61% in regions with endemic infectious lung disease compared to almost 80% in the regions that we don't have the endemic lung disease. This is a sample of the endoscopic ultrasound. This is the probe, and you see that this is a tumor here, and it's passing beyond submucosa and also passing almost like passing the muscularis propria and almost to the subserosa area. So that will give us basically the stage of that rectal tumor, and that can define what treatment we should be giving. And CEA, of course, we need to know CEA, and I'm sure a lot of people understand that. It's a glycosylated cell surface with a molecular weight of 180,000 daltons. The lower limit of normal range is 2 and then 5. But we have to be cautious about elevated CEA because elevated CEA can be seen in smokers and in patients with chronic inflammatory disease. But they're not that high. However, the one that we have to be cautious is they can be high also in other cancers like lung, breast, GYN, and other GI cancers. So it is not useful, the CEA is not useful to do diagnosis and screening of colorectal cancer. However, it is a reliable marker for disease recurrence if it is initially elevated. So that's a way to follow CEA. There is the percentage of patients with elevated CEA, you can see by stage. Like on stage 1, the elevated CEA is only 4%, but on stage 4, you see that is significantly higher at 65%. So going back to adjuvant therapy, just go briefly to the history of adjuvant therapy. We used to give 5-FU only, but it doesn't have any results, effective results. And somewhere along the line, somebody noticed that the medication that we use to deworm the animals and later on to the humans, I don't know how they get to look into that drug. I'm still curious about how they get that. It's supposed to show the immunostimulatory effect. So they did a study adding 5-FU and levamisole, and that shows an improved survival in stage 3 cancer. So we started using that combination regimen as the treatment at that time. However, the biggest problem with that drug is that it has significant side effects, particularly nausea, vomiting, and bloated feeling, and really uncomfortable with this. And recently, it was found to have encephalopathy, so it was withdrawn from the market. At the same time, another group of investigators looking into 5-FU leucovorin as a way of treating using as an adjuvant therapy. As you know, 5-FU inhibits the amygdala synthesis that is necessary for DNA's formation, and they found that reduced folate inside the cell will increase the sensitivity to 5-FU. So folinic acid is a formal derivative of tetrahydrofolic acid, and once inside the cell, they transform into reduced folate. That gives the 5-FU significantly more effective. So with that concept in mind, they started using 5-FU leucovorin compared to observation, and they found that there's an increase in survival of 83% compared to 78% with the observation only. However, the problem with 5-FU at that time was we were giving bolus 5-FU, and it causes significant toxicity, particularly diarrhea and agranulocytosis. So another group of investigators led by a physician named de Gramont used the infusion of 5-FU, and he compared that to bolus 5-FU, and he found that, in fact, infusion of 5-FU is equally effective, but more importantly, it has less toxicity, particularly granulocytopenia. So that regimen, we call it the Gramont regimen, has become popular, and I think we're still using that. Again, the same investigators started adding oxaliplatin into that regimen, and they found that when they use the oxaliplatin, it increases the survival from here to the, and that is statistically significant. However, what they also found is that they did find that in stage 2, it increases the survival, but it is not statistically significant. So at that point, we recommend that adjuvant chemotherapy should be given only to stage 3. Then this mosaic regimen came out, and that study confirmed that giving oxaliplatin, adding oxaliplatin to 5-FU leucovorin definitely is improving, and we started using that as a standard regimen at this point. And this is FOLFOX regimen that includes oxaliplatin, is leucovorin, and 5-FU, and 400 and 600, and at the same time we give oxaliplatin of 85 milligrams every 2 weeks. We give it for 12 cycles, about 6 months of it. The interesting thing about oxaliplatin, however, it is a third-generation platinum. It has less GI, auto, and nephrotoxicity, and it also doesn't cause pancytopenia like carboplatin. However, as a single agent, it only has 5% response. So as a single agent, it's totally ineffective. But when it adds to 5-FU, it potentiates the effect of 5-FU. So oxaliplatin should always be given with 5-FU. Then the big problem with oxaliplatin is the neurotoxicity. There are 2 types of neurotoxicity. That's acute hypersensitivity type of neurotoxicity and chronic polyneuropathy. Acute hypersensitivity type of neuropathy occurs immediately during the treatment or after treatment, and it's induced by cold. So a lot of time when you give the treatment with oxaliplatin, we always advise the patients not to go into cold weather or go into the refrigerator, or in fact, we even advise drinking against ice water or any ice drink because it will trigger bronchospasm and can be dangerous, scary, because we had one patient like that and we didn't even know how to manage it. Fortunately, the patient recovered. So chronic polyneuropathy, however, is different. It occurs in only 15% of the patient, and it's glove and stocking type, and it's cumulative. And that's become a big problem recently because it continues to, it develops after continued exposure of the oxaliplatin, and so we have to stop once we see this, stop oxaliplatin once we see signs of neuropathy in the patients. And somebody else here came out with capecitabine, and that is an oral drug, so it is very convenient. And it is a prodrug of 5-DFUR, which is converted to 5-FU. So it's actually an inactive metabolic drug that changes to active component once it's inside a cell. And it's also found that it has better survival than 5-FU leucovorin. The main problem is it has a side effect called hand-foot syndrome, where we have to monitor that and have to readjust the dose. Dosage of 1250 milligrams per meter square, but that usually is a regimen that's used in Europe, and we found that if people don't tolerate that dose that much, we usually end up starting at 1,000 milligrams per meter square. Now, this is a picture of hand-foot syndrome. This is grade 2 hand-foot syndrome. You see that it's shining palms and sole of feet. People will complain of burning sensation in the palm and the feet. And we have to continue to monitor that. If it gets beyond stage 2, we have to basically readjust the capecitabine. Of course, the problem is not all regimen works, and FOLFIRI, for example, is a regimen that replaces oxaliplatin with irinotecan, and it's equally effective in metastatic carcinoma. However, we found that it doesn't work at all in adjuvant setting. The same is true with bevacizumab, which is the VEGF inhibitor. And when we add that drug to FOLFOX, we found that it's more effective in increased survival in metastatic carcinoma. But it doesn't show to be the same in the adjuvant setting. Tyrosine kinase inhibitors like cetuximab and panitumumab so far is controversial. Couple of data show that they work, and couple of data show no. So there's a large randomized style trial going on, looking into that drug, particularly in those people with KRAS wild type people. Currently, radiation is not indicated in colon cancer unless it is perforated or adhered to adjacent organs or has abscess formation or if the margin is positive. So if we get a clean margin, we don't normally give radiation therapy to colon cancer. Now, the problem is stage 2 colon cancer. It has 20% recurrence rate, and all these studies that we have done so far show that it is improved the recurrence rate, but unfortunately it never reaches the statistical significance to really justify self-giving the treatment. And theoretically it's only improved like 2 to 4%. But in high risk stage 2, it occurs more than 5%. The big thing is if they have the microsatellite instability significantly high, we found that it has better prognosis. And this is basically explaining what the DNA mismatch repair or microsatellite instability is. Here we have this short segment of DNA that is mismatched. It should be either GC or TA. And instead, it was not matched properly. So we have these mismatch repair protein that comes in and fix that and repair it to become normal. But if one of the genes become mutated and the protein is deficient, we see this loss of mismatch repair function. And so you start accumulating. And this short segment of DNA that is not mismatched is being thrown away and discarded. And that we measure as microsatellite test. And here, for example, I'm sure that Dr. Tan has already shown it. This is a MLH1 positive. And here we have this patient is MSH2 negative. And here you have negative finding, and here we have positive finding. And with the PCR on polymerase chain reaction on the tumor DNA, you see the normal pattern, and this is the abnormal when you start seeing microsatellite instabilities high. The interesting thing is that if you have microsatellite instability high, the prognosis is relatively very good compared to people who get either microsatellite stability or low frequency or microsatellite instability. And that's one of the things that we see in stage 2, that if they have MSI high, they have good prognosis. The interesting also is that if they have MSI high, they don't respond well to 5-FU at all. And so here, for example, these patients are the patients with microsatellite instability high, but these patients are the one that was given with 5-FU. You see the percentage alive drop down. So we consider when you have MSI high, they are resistant to 5-FU, and that's one of the reasons why we need to have microsatellite instability tests on these people with stage 2. So we talk about rectal cancer, and I found that Dr. Chody and Dr. Verawal have discussed some. The rectal cancer, we have problem with rectal cancer is because we have a risk of a local recurrence due to absence of serosa surrounding the rectum and close proximity of the rectum to the other organs to make it difficult for surgery. And of course, we also have technical difficulty to get wide surgical margin, a clean resection. And so we found that stage 2 and stage 3 rectal cancer has very high local relapse and risk of metastasis. And so we feel that to control this thing, we will need to have combined chemotherapy and radiation therapy to control local recurrence, at the same time controlling the distant metastasis. But the problem is, when do we give them? And one of the things we found is that if we give neoadjuvant therapy, combining chemotherapy and radiation therapy before surgery, it is usually given because what they found is that a lot of time when the staging was done before the surgery, they always turned out to be understaging. So at the surgery, they tend to be higher than what the workup shows. And they also found preoperative chemoradiation therapy to be better than postoperative radiation therapy. And here's the study that looked into that. This is the incident local recurrence rate, and you found that postoperative chemotherapy has 13% local recurrence rate, and preoperative chemoradiation therapy has only 6% recurrence rate. The same was true with distal recurrence. The postoperative have 36%, and preoperative have 38%. Actually, it's the opposite. Preoperative have a lower recurrence rate. And that's the advantage of the preoperative chemotherapy, is downstaging the tumor and make it much more effective for radiation therapy to be given. And it also avoids radiation-induced injury, because with the surgery you can have adhesions and all the stuff, and that can be in the way of the radiation field. It also increased the number of patients that can take the full dose of the chemotherapy. And of course, we can also control the micrometastasis before it becomes macrometastasis. So the only problem is that, as Dr. very well mentioned, that the preoperative chemoradiation therapies, we may be over-treating some in early stage tumor. But this is the regimen we most of the time use: 5-FU-leucovorin combined with radiation therapy for surgery, and then followed by adjuvant chemotherapy, which usually is FOLFOX, or capecitabine plus radiation therapy, followed by surgery and adjuvant chemotherapy. The interesting thing you have to think about is that if the patient has uses what you call sensitive hand, a patient already had diabetic neuropathy, or if the patient has his professional work includes like musician that needs a delicate fingers, we don't give oxaliplatin. We will try to give FOLFIRI in that setting. But although, like I said, the adjuvant setting with FOLFIRI is not that effective. So the interesting thing is, when we did give the preoperative chemotherapy and radiation, we found that we can downstage 50 to 60% of the time, and 20% of the time it went to complete remission. And in stage 1, in fact, 40 to 50% will go into complete remission. And in one study, 5-year recurrence rate, free survival rates were 90.5%. If it is complete remission, if there is only poor response, there's only 58.5%. But this is the interesting study. I don't know if Dr. Chody will agree or not, but this was a study presented last January, just a month ago, at the ASCO GI meeting, that they found that when you give the chemotherapy, preoperative chemo and radiation, it got complete remission, 40 to 50% case in stage 1, and 30 to 40% complete remission. And what they found is that people who got complete remission, who did not have surgery, have and only after chemoradiation therapy, have 91% 4-year survival, compared to people who have the neoadjuvant chemoradiation plus surgery. So there's some suggestion that we may be able to do just watch and wait after chemoradiation therapy before we consider doing any surgery at all. I think, but then this is just a more or less like a retrospective study, and so we need to confirm that down the line. So how do we follow up? We need to follow up every 3 to 6 months with history and physical, and every 6 months for a total of 5 years, CEA 2 to 3 months for 2 years, then every 6 months for a total of 5 years, and CT scan of the abdomen, pelvis annually, and chest annually for up to 5 years, colonoscopy in 3 to 6 months if not done yet, and if it is done, to do colonoscopy again 1 year, and if that's, then you repeat it in 3 years. So in summary, I just want to say that stage 3 and stage 2, we do give adjuvant chemotherapy, the colon. Low-grade stage 2 is controversial. Like I said, if the patient has MSI high, we don't give the adjuvant chemotherapy. But if the patient is in MSI low, we try to give adjuvant chemotherapy based on the patient's condition. And usually adjuvant therapy is given for 6 months. If there's neuropathy, like I said, or the person uses a delicate hand as part of his profession, we try not to give oxaliplatin. And in the rectal cancer, we will give neoadjuvant chemotherapy with radiation therapy before surgery. Thank you. So at this point, I would like to invite Dr. Fred Smith. I don't know what happened with the projector again. There's no power. Okay. Dr. Smith will discuss the management of metastatic carcinoma. Dr. Smith has the clinical appointment as a clinical associate professor at Georgetown, and also at the assistant professor at Hopkins. And if you think of it, he has been to actually, I don't know if he has 25% Burmese blood. He was born in Burma and left the country when he was like 9th grade.
So, as Dr. Milton said, I was born and raised here. What's going on? Presentation, which I wrote here. Yeah, when you hear me, I understand. So for my non-Burmese speaking colleagues, I just explained that I was born and raised there, and I still speak the language but with a great accent that almost no one understands. Very nice. But I want them that if they didn't like my presentation, you shouldn't, speak near me and criticize my presentation, otherwise I'd be hurt. So with that, thank you very much. I am honored to be here. When the issue of the more important tasks of infectious disease, tuberculosis, malaria, HIV, is defining. Diseases of developed countries, coronary artery disease, and cancer emerge. And one of the things about colorectal cancer, if you look at the global map, is that it's a disease of increased incidence in well-developed countries. This may be dietary, it may be many factors, as Dr. Nielsen has said. But what I learned in a survey that was done was perhaps because of the resource organization that Dr. so sensitive to, that more cases are presented in advanced stage in this country. So my charge is to talk about the role of treating metastatic colon cancer. And although I feel like I'm not an expert without my slides, I'm going to continue. And hopefully
I think we need to change that.
As Dr. Chody said, colorectal, is this better? Colorectal cancer is still about the third leading cause of cancer mortality in both American women and men. The concern is that when they present with metastatic disease, in the past we felt that there was very little chance to cure them, but now with multimodality, combined thinking, combined approach, there is a higher potential of cure even in individuals, as Dr. Chody has pointed out, with metastatic disease to the liver.
and with metastatic disease also to the lung. So metastatic disease then is stage 4 cancer. And this is one where traditionally surgical cure, which is still the only primary way of curing this disease, is not possible. We then attend to systemic therapy. Here we go. Thank you. So how do I advance, Mio? So this is a patient who is a 57-year-old woman who presented with significant abdominal pain and was obstructed and had to be taken quickly to surgery. Otherwise, we would have presented her in a group to discuss what to do. So she had an obstructive lesion in the left colon, which was resected. There were 19 nodes removed, but one was positive for cancer. Postoperatively, we get PET CT, and I'm not sure if you can see it. Do you have the pointer? I'm not sure if you can see it, but there's a small lesion on the liver. And on the PET, it lights up. But again, with resource limitation, you know, you really don't need the PET. A good reading would have shown that to be malignant. It is solitary. So this patient had a liver biopsy. And as Dr. Tan pointed out, the patient had mucin production, CK20 positive. This is metastatic disease in the liver. Is she curable? I think so. And partly it's done because of the combined, so this is the patient's colon lesion, same histology as in the liver. So I'm going to pass over some of these slides. Why treat metastatic disease that cannot be cured surgically, even if there is a potential for no longer resecting liver metastases or lung metastases? One is because it's been shown time and again in studies that there is an improvement in survival, and as Dr. Choti showed you, as we've improved our treatments, there's prolongation of survival now to years, and that the quality of life of patients with metastatic disease treated do better than those who are left without treatment. So a brief history of chemotherapy then. Dr. Mio has talked about 5-FU. Initially we gave it just by bolus. That's not as effective as infusional chemotherapy, but then the resources that you need a pump. And although there are portable pumps, they're not that convenient. So capecitabine is an oral medication that has very similar pharmacodynamics to infusional 5-FU, and I would propose that that be considered, more resource appropriate. With the advent of irinotecan and oxaliplatin, these regimens called FOLFIRI and FOLFOX have increased the response rate, the time to progression, and the survival of patients with metastatic disease. The problem, again, is that you need an infusion pump. There's clear evidence, I think, that Xelox, where capecitabine, also called Xeloda, is substituted for the infusional 5-FU, used with oxaliplatin, and less frequently with irinotecan, leads to the same benefit. So this, I would propose, might be a more reasonable treatment. Now, of the past decade, the excitement has been of anti-vascular endothelial growth factor and also of anti-EGFR treatments. So I won't dwell on this too much, other than to show you that when compared using leucovorin 5-FU to adding additional drugs, there's been significant, fairly consistently significant improvement in time to progression and survival. And this is just, again, to show that if one adds irinotecan or FOLFOX, there is a good median survival. Now, in our situation, we have shown that adding vascular endothelial inhibitors like bevacizumab, Avastin, will substantially improve the response and the survival in patients with metastatic colon cancer. Hasn't helped in adjuvant disease, but in metastatic disease, I'll show you some data to demonstrate that. There are other, anti-VEGF and anti-EGFR, some of which are pills that are coming along that have added to our armamentarium, our way of being able to manage these diseases. Dr. Mio has already shown you this molecule of the immunomonoclonal antibody bevacizumab, and how it works is by reducing the proliferation of neovascularization that the cancer has, which may impede actually ingress of chemotherapy into the cancer. Now, the EGFR is a different receptor, and the way that cetuximab works is by blocking the dimerization, which, if left unimpeded, instructs the nucleus to survive, to proliferate, and to metastasize. The problem with it is that about 25% of colon cancers will have this KRAS mutation. And Dr. Tan has pointed out that she will sometimes measure the KRAS mutation. If that's the case, cetuximab is, first of all, the KRAS mutated cancers are more aggressive, and secondly, they don't allow for cetuximab to interfere with the pathway. They're already on autopilot to continue that. So these next couple of slides are just summaries of the contribution of bevacizumab to chemotherapy. Without bevacizumab, with bevacizumab, about a 5-month improvement in survival, and that's been shown fairly standardly across the board. And these are just a compilation of other studies, again showing that adding the VEGF inhibitor bevacizumab adds to this. Studies with EGFR inhibition, not quite standard because in the beginning the KRAS mutation was not recognized. And consequently, if you give EGFR inhibitor to KRAS mutated patients, no help. Using both, even in the KRAS wild type, has now been shown not to contribute anything but toxicity and expense. So we don't do that. So there are other drugs coming in the advent of metastatic colon treatment, so that now, in the beginning when I started taking care of patients with malignant disease, we only had 5-FU. And all of a sudden, we have leucovorin 5-FU, we have capecitabine, we have FOLFOX, we have FOLFIRI, we have Avastin, FOLFOX, bevacizumab, FOLFIRI, cetuximab, and even more are coming. There's a pill, regorafenib, which will sustain stability, although not improve necessarily response rate. And there are more to come. So again, in trying to think about resource limitation, I think that when we get together in our group, when we encounter a patient with metastatic disease, the first thing, as Dr. Chody pointed out, is even when they have metastatic disease, are they potentially resectable? And if so, the timing of chemotherapy versus surgery is discussed, and then the choice of drug is used. If they are not resectable, in other words, there is really no chance of resection for cure, one thing that always comes up for us is clinical trials. We're not curing the majority of these patients. We're trying, nonetheless, to palliate and improve their quality of life and survival. If there is an interesting clinical trial, we will then recruit our patient to participate in that. And thank you very much.
I think what we're going to do now is we're going to discuss tumor boards, since the speakers have all done for this particular disease. What I like to do is I like to invite the faculty to come up here and sit. Dr. Suam, Dr. Tan, Dr. Chody, Dr. Berrywell, and Dr. Smith, and Dr. Wang. please come up. What is going to happen? Right now, we're going to present a couple of cases as a sample, and then you now use the clicker. Is it what function?
Yes.
Okay. As I mentioned, you use the clicker, and there will be a couple of questions that's going to pop up. It's like I said, we're not really basically testing your knowledge. We're just trying to see how people treat here so that we can have the understanding of what we can discuss in the future about how to approach this disease. And then, if we have, what I'm trying to do is like a relatively quick and this discussion, and we will, if you have any cases in regards to cancer that you would like to discuss or present, like I said, as educational value or for management, please do so. This is all open, and we would like everybody to participate in the discussion, because the cases that we have that I'm presenting here for colorectal are actual cases that we did at my institution. So that doesn't mean that they agree with my institution approach. Hello? And it's basically my fellows' approach. So that doesn't mean that they will agree. So this would be what I'm thinking of, is trying to see how people approach the disease. And like I said, there's so much controversy in a lot of the disease management that we need to do it. Charlie, would you come up here and be a moderator? Doug, can I get... No. I can't find the cursor, and I have to get out of that.
So, unlike Dr. Smith, I don't speak Burmese, but I will. I think the one word I've learned this morning is Mingalaba. Is that right? I've used my one word now. I'm done. So I'm Charlie Penley. I'm a medical oncologist in Tennessee. I'm a community doctor like many of you. And one of the things we do in our hospital every Wednesday morning is we have a gathering where we have new cases that are brought by our surgical colleagues, our primary care physicians, the radiation oncology colleagues, and we come together in a conference room around a table and we talk about the cases. And I hope that you all have the opportunity to do that, but I think that really reinforces the concept that oncology is a team sport. We very rarely operate alone. And so these cases, and I'm not at all familiar with the cases, nor am I familiar with the cases on Wednesday mornings at my hospital, so this is not at all unusual. But so we'll start with this one, a 50-year-old man who presents with shortness of breath on exertion. He's been having weakness and he fatigues easily for the past month. He has a history of coronary artery disease, and you can see that he's had stents. He has a family history with colon cancer, and you see that he is a bit tachycardic. He looks to be ill. His performance status is 2, and he is anemic. His hematocrit's 29%, with an MCV that's low, suggesting iron deficiency or chronic blood loss, slightly decreased platelet count, and an LDH that is a bit elevated. And so to advance the slides, we do this one. So this is a question for the clickers. You have them in your hands. So what do you do now? Do you test his stool for occult blood? Do you order a CAT scan? You order a barium minima, or you call a cardiologist? You know, when all else fails, you ask for another specialist, right? You ask for another doctor to help out. So use your clickers now, and then I guess someone is going to tabulate the results.
I don't know what happened with them.
So use your clickers.
And we'll just do this for a few seconds, and then we'll move on. You won't get a grade at the end of the conference.
Sorry, now you know.
Okay, do them again. We'll make this work.
Okay.
Okay, so here we're going to get the results, I think. Doug says that most of us will do a stool test for occult blood. I think that's reasonable. But the next step then will be to go further with his evaluation. You see that his stool is positive. His iron level, based on his serum ferritin, is very low. His iron and TIBC levels are iron is low, TIBC is high. The percent saturation is borderline low, if I remembered my values correctly. So what's the next step? Here's another clicker question. Do you refer for a endoscopy or colonoscopy? Do you order a barium minima, or do you order a CT scan? Doug, you're going to have to operate this because I don't know how. And so use your clickers now, if you will. And the survey says, here we go. And this is exactly what I would do in my medical center at home. You have the GI tract evaluated. Now, we've got, I don't know where it's appropriate to engage our colleagues at the tables here. Should we just work through the case and then we'll talk about the management? Okay, so we have a colonoscopy done by a gastroenterologist. It shows a large mass obstructing or nearly obstructing at the level of the hepatic flexure. And a biopsy, as we heard earlier this morning, is positive, probably for a well to moderately well-differentiated adenocarcinoma. So this is very common wherever you are, and so this is the next. The question is about the next test: a CT scan, a CEA, a surgical consultation, a PET scan, or all of the above. And I think that. There are multiple possible answers there. So we'll use your clickers now, please. Okay. We all hit our buttons. I expect we'll see, well, so all of the above. Some would refer immediately to a surgeon. Some would order a CT scan. I think all of these things are appropriate. And in my community, and I bet it's the same here, the timing will dictate the order of these things. The availability of a CT scan, the availability of a surgeon to see your patient. I can do the blood test in my office. The PET scan, I understand you all don't have access to PET scans here yet, although in speaking with one of the diagnostic radiologists, I understand that that's very near. Within 4 to 6 months, I'm told, PET scans will be available here. So PET scans are useful but not mandatory. And so this patient would need many, or if not all of these diagnostic tests.
May I comment, Charlie?
I'm sorry, please.
I would say, though, that in that I would not recommend a PET scan at this stage. Doing the three makes sense: the CEA, the consult, and the colonoscopy, or I think there was added colonoscopy. But I think there's really limited role this early on to do a PET scan in this case, and I would say that's a wrong answer.
Well, I think you're right, and I think PET scans are useful in some circumstances, but with early stage colon rectal cancer, probably not so useful. So we have a CT scan showing a big mass in his transverse colon with some low density mesenteric nodes, but no evidence of disseminated disease. The CEA level is moderately elevated at 26. And here is a picture for our pathologist to look at and give us a quick read. But I think this represents an adenocarcinoma.
Yes, I agree with you. Yeah, well, it does show some normal mucosa at the left field, and then you see the tumor that consists of very closely packed glands, and on the surface you do make out the presence of some papillary structures. So it's moderately differentiated adenocarcinoma.
Good. See, I think our pathologist brings the same slide to the conference every week because they know they can confuse me. I'm easily confused by, I didn't do so well in pathology in medical school. So it's a moderately differentiated adenocarcinoma, and it appears that there must have been a surgical procedure here, and we have 48 regional nodes removed and 1 positive. So as we heard a little earlier, that is I guess that's a T3 or T2 or 3 in 1 lesion. And here is the staging. And, oops, sorry. So the stage, here's your question. Hit the clickers on this one, and Doug will tabulate this. And I can't remember the depth of invasion there. I don't think it was transmural, was it? I didn't think so.
Well, the image didn't really show the full thickness, but it did
was
look
in the
like it was
muscularis,
invading the muscularis propria at least.
So this group is saying 3A, and I agree with you. Hope we all agree. And then here's a slide representing survival. Sorry? And so after surgery, this patient has stage 3A disease. When do you repeat the CEA to see if it's coming down, to see if it's normalized? This is a good question because I'm not sure I know the answer to this. So we'll use your clickers now, if you would. And the group generally says 4 to 8 weeks post-op, and I can't remember the serum half-life of CEA. I'm sure that it's clearly the half-life is significant, and so ordering it too soon, you wouldn't get a valid answer. So here we go. 4 weeks later, it's 3. It's come down to normal range. And then this is a question about post-operative chemotherapy. For those of you, I think there were some medical oncologists in the room, and we've just heard a talk about adjuvant chemotherapy. So what would be a reasonable choice for post-operative adjuvant chemotherapy in this patient? There you see the choices, and so use your clickers, please. Whoops. Don't give it away, Doug. So what do we have the results? Oh, there you go. And so this means that Dr. Milthant gave a nice lecture, and everybody's in agreement there.
How old was the patient?
I don't remember. 50. So a young, otherwise pretty healthy man, except he had...
Is there ever any role for monotherapy in a patient who's that age for adjuvant therapy? In the adjuvant, let's say a piano player or a violin player or something like that, would you ever go with monotherapy? I mean, just to have a little discussion here.
FOLFIRI is questionable effectiveness as an adjuvant. I don't know what you...
I think that's a very good question, and the other would be to use capecitabine.
There is advantage to adding oxaliplatin. You do get a bump in your control rate, but when you look at it with a patient maybe who has other morbidities, who has other illnesses, or who has other interest, I think capecitabine is a very reasonable choice.
And I don't know if it was mentioned in the talk, if I can, what's the status of the ongoing studies comparing 3 months to 6 months of FOLFOX? Because the concern is the cumulative toxicity, and I think that's going to have a big impact if indeed that's a positive study. Where are we now with those trials?
That is a study that we're conducting in the United States. Initially, because of our fear of cancer, we tended to, I think, overtreat. And then it's hard in our country to just, in the U.S., because I consider Myanmar my country as well. But it's hard to back off. So unless we do a clinical trial, it's hard to back off. So there's a clinical trial comparing just 3 months to 6 months. In addition, they are randomizing, Dr. Mio had talked about using celecoxib, Celebrex, to try to protect from colon cancer. So there's a randomization between 6 versus 3 months, and another randomization between Celebrex and placebo, still ongoing.
Yeah, one of the problems is that FOLFOX, we have not been able to finish all 12 cycles most of the time. And like I said, because of the neuropathy, we end up stopping it somewhere around after about 3 months or so. So basically, that's a big reason, and in fact, we continue with 5-day leucovorin after 3 months or so because the patients can't tolerate the neuropathy. I don't know if that's that true in Singapore.
I think that would be true. I mean, I think that a lot of times near the end of the 6 months, I mean, we're dropping or significantly reducing the dose of oxaliplatin, both because of neuropathy and sometimes because of myelosuppression as well. So I think that I think it's the majority of our patients don't see the full doses of oxaliplatin all the way through.
I think it's a shame that we don't have the microphone from the audience. I don't know if anybody
Clearly,
have a difference in opinion regarding the treatment.
Please raise your hand so we can, and we really want this to be
discussion.
interactive.
There's not discussion among here. It's going to be. It should be discussion
So please,
among everybody.
Speak up, and we'll try to get a microphone to you.
Yeah, just raise your hand, and I think they will come and give you the. Okay, there is a.
But I do think that the whole issue of able to complete 6 months of FOLFOX is a real one, and in my practice as well, we have difficulty with the neuropathy. And it's not so much the acute cold sensitivity. We've learned how to coach people around that,